Well, it's always a pleasure to go after Liz, and I'm really honored to be here and be able to talk to you a little bit about what our learnings have been in a large healthcare setting in trying to look at, I think, which is a big question that we've all had, which is if we could actually get to the point of including prevention of domestic violence, well, could we do it? And I guess my answer to you, based on our experience, is yes, we can. And I'd like to share with you a little bit about what that has looked like. Some background on Kaiser Permanente, because most of the people who are on the West Coast are very familiar with this particular health plan. On the East Coast, maybe not so, but we are one of the largest nonprofit health plans, and we serve 9 million members. We are active here in the Mid-Atlantic region, and Ann Jordan, one of the nurses that leads women's health in the Mid-Atlantic, is actually here today, and she's been doing training of our OBGYN providers to implement the IOM HHS recommendations. Where I started my work was in Northern California, and I think that Kaiser brings a really rich opportunity, and other healthcare settings do as well, to be a laboratory for how do you really implement and test new models of care. And, because we provide the full scope of care, both inpatient, outpatient, specialty, primary care, and mental health, and have a fully implemented electronic medical record, lots of experience with chronic disease management, a pretty well-respected research component, and a long commitment to prevention and patient information that's grounded in social mission, you can do some stuff in that kind of setting that I think develops models that then can be useful to people in other settings as well. So back in 1998, I received some funds to implement and test a new approach. And we decided at that time that we were going to step away from what had been done, which was develop guidelines, focus in on clinician training. And instead, we were going to look at the whole healthcare environment. We would use learnings that had been developed from systems approaches to other forms of injury and to public health responses to other tough topics. And we'd see what would happen if we decided that the whole healthcare setting was going to be designed to try to improve our identification of domestic violence, and then more importantly, not just identification, but connection to the next set of resources and help that a person needs. So this systems model approach is sort of our picture of how that all fits together. And we've got some good data over the last 10 or 12 years that shows when you put that kind of approach in place, you can really dramatically increase identification. So what this shows you is a 6-fold increase in identifications. And what I mean by that is an individual who's met with a provider where domestic violence has been identified and that has been documented in their medical record. And what you see here is different colors showing where that identification took place. So the red bar is the emergency department. That's where we started. That's where most health plans start. The bulk of the identification occurs in a place where it's sort of like, well, all right, a black eye. You're kind of forced to begin to consider that as a possibility. Green is the mental health, and then blue is ambulatory care. And you can see that over time, as we've implemented this approach, more and more of the identification occurs in ambulatory care. This, to me, speaks to a much more robust approach. It means we are asking and identifying well before someone presents with acute injuries. And I'm pleased to say that we've not only been able to move from a few facilities that were pilot facilities in 1998 through all 49 of our facilities in Northern California, and now we have work underway in all of the regions in Kaiser Permanente nationally. So I think we've got some useful learnings about what it takes to put this in place, what it takes to transfer it, and then what it takes to scale it. And I think it's important for all of us to hear that this did not involve big sums of money. It didn't involve new technology, lots of buildings. This involved learning how to connect the dots, and those are things that we can do in one healthcare setting that will be transferable, I think, to others. So what did it take to do this? Well, it really required thinking beyond just clinician training and guidelines to that model of care that I showed you. It required thinking about this from a clinician point of view. What do I do when the patient says yes? And from the patient's point of view, what will happen if I disclose? And making sure that what we put in place addresses both of those issues. It requires having metrics that show whether you're making progress. It involves figuring out how to use the tools of quality improvement, small tests of change, PDSA, and what have we learned from scaling up and dissemination. And then finally, it has to be integrated with other large healthcare initiatives, whether it's reduction of disparities, whether it's being attentive to cost, whether it's patient-centeredness. It has to be fit well with those. So I'm going to say just a few words about what does this look like in a very practical way. Well, it requires a supportive environment that communicates to a patient, this is a place that you can come for assistance. I wonder how many of you had a chance to pick up the summary of this work when you came in. If you didn't, how many people didn't get this? Maybe we'll see about making some additional copies, because then you don't have to think about taking in all the information that I'm moving through very quickly, because this is really a description of how we implemented this and scaled it up for an Institute of Medicine workshop that actually Jackie Campbell chaired. The inquiry and referral, this is the clinician part. If people only do the clinician training, you don't get that much to happen, and we heard about that today. But what we ask our clinicians to do has to be clear and focused, and it has to look just like what they do for other things, whether it's asthma or chest pain or any other medical condition. But it's got to be that the right thing is an easier thing to do, that it fits with their knowledge and expertise. The community linkages, as Liz just mentioned, are so vital for this condition. What many women need, the things that are going to be life-saving for them, don't exist in the bricks and mortars of the clinics. They exist in partnerships and in resources that are out in the community. And this on-site response, one of the 4 pieces of this coordinated approach, is really critical. It has to be a trusted, easy, and reliable response that a clinician can offer. Now, not every facility or every clinic is going to be able to have social services and behavioral health. And so that piece has to be something that can be customized to what's available, so that even in the rural area where a doctor may only have the opportunity to have a corner of their clinic where someone can have some privacy and contact the National Domestic Violence Hotline, that has to have been thought out in advance so that the doctor knows exactly what they're going to do, or the nurse knows how to help that patient get to the next step. Now, one of the things that's been vital for us about this work is really a clinician and research partnership. It was the findings from that initial pilot that allowed me to get the resources to go ahead and move this forward through our other facilities. And what we decided to look like in conjunction with my research partners was not the traditional knowledge, attitudes, and practice that frequently is used, but really a change in the member experience and a change in the provider behavior. So what we looked at using a pre- and post-intervention phone survey was what members recalled, and there was a statistically significant improvement in patients recalling being screened for domestic violence, in their awareness that the clinic was a resource for them for DV, and interestingly, their satisfaction with Kaiser as a health plan because what they saw we were doing around domestic violence. This turns out to be an interesting piece of information that I'll talk with you about in a few minutes. Also, what we noticed was an increase in self-referral pre and post of women choosing to go forward with mental health services themselves. What we noticed on the clinician side was a tripling in the number of patients they identified with domestic violence and making a referral to mental health, and they felt good about the program that was in place. There were some additional learnings that we had, but it was part of that really important research clinician link, which I don't think can be underemphasized in our moving forward. Many of you may have seen the article that came out about a year ago by Patricia Ocampo looking at what can you tell from meta-analysis about hospital and clinic-based screening programs. And what she found looking over these is that, in fact, a multi-component comprehensive approach is more effective in increasing screening. So that's, I think, good support for what we've done. And also she identified some key things that were typical of those healthcare settings that were being successful in increasing screening. You can see those there. So I'll say a few words now about what did it take in terms of scaling up. And one of the things is really having local facility-based presence for that work. And in this case, it's a nurse or physician champion. Stepwise implementation and tools so that each facility or clinic didn't have to reinvent the wheel. And these tools include things like the roles of members of the team, templates for referral, clinician education resources, patient information, and the development of intranet resources so that wherever you are, whatever your facility is, when you're linked together as we are as a health plan, you can find the information you need right there at the point of care. So this doesn't have to be worked out in each individual clinic where there are commonalities that suffice. And it also turned out that leadership and team development for the folks that were leading this work was important, as well as a way to share best practices. Another really key part was coming up with metrics. That is, how can we find out whether we're making progress? And we were able to link our quality improvement measures to NCQA, and you can see what the measure was that we are meeting through our following of data. And when it's possible to use automated databases, and that will be true as we look to the future more and more in healthcare settings, this is much better than trying to use chart reviews to figure out how you're doing. But the measures have to make sense clinically. They have to be something that a clinician looks at and says, yeah, that's right. Identifying someone is the first step, and then the second step is making sure that they get to the next services they need. Here's an example. You saw a little bit at the beginning of one of the kinds of pieces of information we collect, which is raw numbers of people, men and women, identified as experiencing domestic violence. But being able to have an identification rate, that is when we look at the people who we're identifying, how does that compare to how many we think are experiencing domestic violence? So we've got the gross numbers, we've got what percent get mental health follow-up, and then we have an identification rate. And we can use that to help facilities compare how they're doing to each other. You can see some are doing very well. We can ask those facilities to share with us what their best practices are. And this is, if you're in a clinical setting, this is what you see and do all the time. We do this around mammography, around asthma, around hypertension. This frames intimate partner violence detection and referral as part of the everyday work that we do in the healthcare setting, matching the performance of the best, taking advantage of the competitiveness that clinicians feel with each other to do the very best job. I think it's important to say something about technology. That's been something that's been really important part of moving this forward, both in terms of supporting clinicians, and as Jackie mentioned, the electronic medical record offers some really important opportunities as reminders for best practice alerts, for models of documentation that really make it easier for physicians to do their job and for nurses and social workers as well. We do a fair amount of online clinician training so that people get it in bits and pieces very frequently and can model how you ask and how you respond. It also turns out that using technology to engage patients is important. I would guess that most of you, the last time you had something you weren't sure what it was, Googled it before you bothered to call your doctor. Well, our patients do that as well. And making sure that there is consistent, reliable, and top-notch health information that includes domestic violence that's part of a healthcare experience is something that we found to be very helpful. It also turns out that less and less of what we do happens in the office. So as we're all sitting here thinking about the healthcare setting of the future, we need to be thinking about other ways that people get information. We get 1 million calls to our advice and call center each month. That's an opportunity, because we have highly skilled nurses who answer those phone calls, to offer intervention and information about domestic violence. Here's a quick look at what our intranet site looks like for our clinicians. This is Mid-Atlantic has one as well. It shows the doctor or the nurse exactly what to do and links them to the resources that they can give to a patient that's community specific. I'll go ahead and, since we're short on time, I won't really talk about some of the other ways in which the intervention varies a bit, is harm reduction focused, as Liz mentioned. But with teen sexually transmitted infections and pregnancy testing, the kind of intervention that we ask our clinicians to make is different than when it's part of a well woman visit. When we're talking to our patients around asthma, we'll ask different kinds of questions. Is anyone interfering with your ability to take care of your asthma, like preventing you from picking up your medicines or coming in to see the doctor? So that the task of our care manager is really focused on the job that she needs to do, which is help the patient improve their asthma, but incorporates acknowledgement that it may be something that's going on at home that's preventing them from being in good control. There have been some other really important learnings along the way. I think I mentioned one of those, this partnership between clinicians and researchers. The engagement of our research, it was fabulous to hear today about, the engagement of our workforce as a factor in creating a supportive environment where our own employees understand what resources are available for them. They're much more effective in talking with members who they either suspect or know are dealing with issues at home. One thing that's been sort of serendipitous was learning, this came up when I thought about the guns. How do you take a gun out of a person's home? One of the things that we learned was getting in the way of our clinicians asking was that they weren't necessarily seeing their patients by themselves. And they had to think about these sneaky ways to send a patient out for an unneeded urine test or for something else so that they could actually have someone else on the team ask the round of domestic violence. Well, a way around that is to say, with all of our patients, they have some time with their clinician by themselves. And when that becomes part of the policy of how you room a patient so that other sensitive issues, and it's not just domestic violence, it can be sexuality, it can be drug and alcohol use, it can be incontinence. It becomes something that the clinicians then expect is part of what they will do with their patient, and it's easier to include IPV. So what does it take to move from recommendations like the IOM or HHS into practice? Well, having a clear goal. For us, it's that it's going to be part of everyday care, thinking in some new ways, having metrics that show whether you're making progress, integration with other healthcare priorities, and then rapidly spreading what works. And I just want to say a couple words about integration with other healthcare priorities. These things are absolutely critical for our future healthcare setting. And if we can't say in an elevator speech how domestic violence helps ensure patient safety or is evidence-informed or helps us with efficiency and cost, we're not going to really be able to sustain this work. So part of my job is to really make sure that we have stakeholders. And here's one of our CEOs and his way of showing why he thinks domestic violence is an important part of what we do as a healthcare plan. This is not a man that necessarily cares about this actual topic in and of itself, but he thinks it's important and can put it in the terms that other CEOs will also understand about why they should embrace this as well. I think there are many learnings that we can get as we move this from Kaiser Permanente into other healthcare plans and as we move what our work is here in the United States into other countries. This is a bilateral exchange of learnings because what comes back as we understand what other people do with this work really helps enrich ours, and it certainly has for me. So what should we be working on right now? And I think I'll go ahead and stop. I think we're probably over time. But outcome measures. It's not good enough to identify someone in a healthcare setting. We need to be able to show that that identification really leads to improvement. We do that with hypertension and diabetes and so forth. We need your help in thinking about what are appropriate outcome measures that we can use. So I think you can read the other things here, and I'll go ahead and stop and open it up for questions.
I did have a question, and thanks for that. In screening, if we're screening men as well, and even though it's done privately, are there any measures that you can take so that that wouldn't be a tip-off of, a doctor's investigating this issues, or are they screened the same way?
So your question is, are we screening both men and women? It varies from clinic to clinic. In some places, all comers are asked questions about how things are at home. Do you ever feel frightened or threatened by your partner? And so that allows us to ask men or women about that issue. And you said, is it a tip-off?
I'm thinking about maybe a married couple who come to the same facility and would be seen separately, but if the partner was abusive, his being asked the questions might endanger her. He'd be concerned that she was being asked the same questions.
Well, that's possible, but if it's routine, just like with the rooming alone, it's something that everybody gets asked. So it's not a suspicion that she has in some way created a signal that she should be asked. But I think that's important data from the harm question about what came out of the ARC report is that people aren't reporting that there's harm as a result of screening. That doesn't exactly go to your question, was if we start asking men, will they assume? But we just haven't seen that. It's been a concern, but it hasn't been something that's emerged.
Thanks.
Yeah. Thank you. Great.